watching with her coat still on, one hand on the door. She'd just been diagnosed with high blood pressure, and I'd written a prescription for lisinopril, a medication that's been around for decades, that costs almost nothing as a generic, and it works really well. And she looked at me and said, "Is this going to be expensive?" I had no idea. I knew the drug, I knew the dose, I knew her blood pressure numbers and her kidney function and whether this medication was right for her. But the actual cost that she'd face at the pharmacy counter, I genuinely could not tell her. Not because I didn't care, I did, but because the information just wasn't available to me in that room at that moment. That's not a story about one doctor, that's the entire system. This episode is about a gap that almost nobody talks about, the gap between what physicians know about medicine and what they know about what that medicine will actually cost you. It's a gap that has real consequences. People skip prescriptions, they ration insulin, they delay procedures, not because they don't want the care, but because they cannot afford it and they were never warned. And here's what makes this uncomfortable. Most patients assume that their doctor knows. They think that when a physician writes a prescription, orders a test, that there's some calculation about cost. There usually hasn't been. To understand why this happens, you need to know how information flows, or more accurately, doesn't flow in American healthcare. When you see a doctor, your physician has access to your medical history, your test results, your medication list. What they don't have access to is your specific insurance plan's formula, which is the list of what drugs your insurer covers, at what tier, your current deductible status, your out-of-pocket maximum, or what specific procedure will cost at a specific facility on your plan. The information exists, it's just siloed. Your insurer has it, your pharmacy has parts of it, but the clinical software that we actually use, the electronic health record, does not typically display it in real time. Some systems have started adding cost-checking tools, but adoption is uneven and the tools are imperfect. There's also something more systemic at work. Medical training has, for most of its history, treated costs as someone else's problem. You learn pharmacology, we learn dosing, we learn side effects. We don't necessarily learn that the drug that we're prescribing costs $400 a month on one plan and $12 on another. That's not a gap from negligence, it's a gap in how the profession was built. And the system built on top of that is not exactly designed to close it. So here's the question that drives the rest of this episode. If physicians don't know what care costs, and patients can't always find out either, who has that information? And what happens to patients who fall into the space between what's prescribed and what's affordable? Some physicians want to help their patients afford care. The problem is structural, and it runs deeper than most people realize, even doctors. The cost transparency failure. Let's talk about what physicians actually have in front of them during a visit. The electronic health record, think of it as the digital interface that doctors use, is primarily built around clinical documentation like diagnoses, medications, orders, notes. It was designed for medical decision-making and billing, mostly billing. It was not designed to show you that drug A costs $240 on your plan, while drug B, which is equally effective for your condition, costs only $18. A 2019 survey by the American Medical Association found that only about 30% of physicians had any tool available at the point of care to check a patient's drug costs or coverage status. The other 70% working blind. Some tools have emerged to help real-time benefit check tools that some EHRs now offer. Manufacturer discount programs like GoodRx and CMS require transparency mandates for hospitals. But these solutions are fragmented. Hospital price transparency rules went into effect in 2021, but compliance has been inconsistent, and the data, when published, is often in formats that are difficult for patients, much less physicians, to interpret. The result is a system where a patient can leave an appointment with a treatment plan that is clinically sound, but financially impossible for them to follow. And nobody in that room knew. Financial toxicity is a clinical problem. There's a term oncologists started using about a decade ago called financial toxicity. It describes the financial harm caused by medical bills, not just bankruptcy, but the downstream health effects. Patients who experience financial stress from their medical care are more likely to skip doses, delay follow-up, and avoid disclosing symptoms. That's not a money problem. That's a health outcome problem. A 2019 study published in the American Journal of Medicine found that 25% of Americans reported not filling a prescription because of cost. Not uninsured Americans, all Americans. And a 2022 survey by the Kaiser Family Foundation found that 29% of adults said they had not taken medications as prescribed due to cost. For insulin, a drug that is not optional for people with type 1 diabetes, the numbers are stark. A 2021 study found that 1 in 4 insulin-dependent diabetics reported rationing their insulin because of cost. People diluting doses, skipping days. I see this in the emergency department. The outcomes from insulin rationing can include diabetic ketoacidosis, which is a life-threatening condition where the body breaks down fat too rapidly for a lack of insulin, and in some cases, death. This is happening in the wealthiest country in the world. Why physicians don't ask? Here's a harder truth. Even when physicians know that cost might be a barrier, many don't ask about it routinely. Research published by the Journal of General Internal Medicine found that financial concerns are discussed in fewer than 40% of clinical encounters, even when patients have them. Physicians cite time pressure, discomfort with the topic, and uncertainty about what they could actually do with the information. That last part matters. There's a certain futility in asking a question that you don't know how to act on, and frustration. If I don't have access to your formulary and I'm not sure which alternatives are covered, asking about cost can feel like opening a door I don't have a key to, or a can of worms when I don't have a hook. That logic is understandable, but it's also frankly a problem. But here's where this gets more complicated and more important. The issue isn't just that physicians lack cost information, it's that the incentives of the system actively work against cost transparency. Hospitals' negotiated rates with insurers are often confidential. Pharmacy benefit managers, the companies that negotiate drug pricing for insurers, operate with remarkable opacity. And the price of a procedure or medication can vary by a factor of 10 depending on where you get it, what plan you're on, and what network agreements are in place. So the question becomes, is this a fixable information problem? Or is the opacity itself a feature of the system, not a bug? I have done an episode on this in my employer healthcare episode, so please take a look at that. The price of your medication isn't determined when your doctor writes the prescription. It's the result of negotiations between your insurer, pharmacy benefit managers, the drug manufacturer, and the pharmacy. And almost none of that is visible to the person who is actually treating you. What this means for patients is that the most important thing to understand is this. Cost concerns are a legitimate clinical issue, and you have every right to raise them. The stigma around money in medical settings is real. Patients often don't bring it up because they don't want to seem difficult or they assume their doctor knows. Neither of those things should stop you. If you're prescribed a medication and cost might be a barrier, tell your doctor. You're not alone. It's not because they can always fix it, but sometimes they can offer a generic alternative, a different drug in the same class, samples from a manufacturer, or referral to a patient assistance program. They need to know that cost is a concern to even offer those options. If you're facing a significant procedure and cost is a concern, you can ask the hospital for an estimate. Since 2021, hospitals are legally required to publish their prices, although finding that information in a usable format is very difficult. Tools like GoodRx and Cuban's Cost Plus Drugs can sometimes reduce medications to a fraction of what you would cost at a pharmacy. These are legitimate resources worth knowing about, although they work differently depending on the drug and your coverage. Here's some questions worth asking. Is there a generic for this? For many brand name drugs, a generic equivalent exists at a fraction of the cost. Physicians don't always default to a generic unless you prompt this. Is this on your formulary? Hey, your pharmacist or your physician often can check your formulary. And what happens if you can't afford it? A doctor who doesn't engage with that question isn't doing right by you. There are options, but they need to know that the issue exists. Here's what I keep coming back to. The physician-patient relationship is supposed to be one of the most trusted relationships in a person's life. And right now, patients are logging out of appointments without the information they need to follow the advice they were given. Not because anyone personally failed them, but because the system withholds that information from everyone in the room. That's not a small gap, it's a structural failure with human cause. In our next episode, we're going to follow that thread a little bit further. Because even when your doctor knows exactly what treatment you need, even when it's clearly the right call, there's a process that can stop it from happening altogether. It involves a form your insurer sends, a clock that starts ticking, and sometimes a different doctor or no doctor at the insurance at the company making a decision about your care. That's what prior authorization is, and the stakes are higher than most people know.